Hello and welcome to Opt to Thrive, episode number 2, Hormone Havoc, how it's not all in your head.
Welcome to Opt to Thrive, your go-to podcast for women's wellness in midlife, designed to educate, support, and inspire you to live your very best life. And now your host, Dr. Karina Sims.
It's another amazing, clear, sunny autumn day here on the farm. Lots of autumn color out in that garden. We just have the absolute best weather here, don't we? In sunny Riverland in South Australia. Even when it's cold, the sun is almost always shining. Absolutely love it. I'm looking out today over what I've been calling a daisy tree. It's a massive, I suppose, shrub. I've pruned the top off of it so I can see the mulberry tree behind it. And this shrub is covered in little yellow daisies this time of year, and it's just like a really happy little tree. So today, as I said, we're going to get into some hormone discussion. This is a really popular topic. It's one of the things that I see most often in my practice. If you're 35 years old or older, you're going to want to listen up, especially if you've noticed some changes in your body that you cannot explain, like fatigue or exhaustion, brain fog, feeling muddy, lack of focus or mental clarity, having trouble remembering things like walking into the room to get something, walking back out without it, and totally forgetting what you went in there for. Unexplained weight gain, right around your middle. Changes in your periods, maybe they're a bit heavier, maybe they're a lot heavier. Maybe they're lighter. Occasionally you might miss one, or they're getting more irregular altogether. Breast tenderness, new headaches, trouble with your sleep, getting to sleep, staying asleep, new or worsening anxiety or other mood disturbances for no good reason. Low libido, that's a big one I see a lot of. Heart palpitations, genitourinary symptoms, so recurrent urinary tract infections, vaginal dryness, burning, itching, irritation, discomfort when you wee, having to go more often, or you've got a real sense of urgency like you really need to get there now. Painful intercourse, bloating, or hot flashes. These can all be symptoms of perimenopause, something we're going to break down a bit more today. Now, these symptoms, importantly, can also be caused by lots of other things. So it's really important that we have this discussion with our doctor so that we can do a diagnosis of exclusion, meaning that we've ruled out all the other things that can be happening, and we can then confidently say, perimenopause is causing these troubles for you. Today we're going to get those definitions right, and we're going to learn the differences between perimenopause, menopause, and postmenopause. I think a lot of women are still confused about the terminology. I think there are some doctors that are confused about the terminology as well. We don't get the best training in this area, which is one of the reasons I'm doing this today, and I'm going to talk a bit more about that in a minute. We're going to talk about what's happening in your body during these phases of life that all of us women are going to go through at some point, and why it is so important that we get the management right, not only for our physical health, but for our mental health as well. Now, as I said, all of us are going to go through these stages in our lifetime. So for those of you who aren't having any symptoms yet, or even if you're one of the lucky 20% of women who will breeze through this period in your life, there are still major risks to your health that you need to know about that are happening behind the scenes. Even if you don't have symptoms, changes in your body are happening that put you at risk, and you need to know about it. It's a really interesting time in medicine right now. It's becoming apparent across the board, even internationally, we're not doing a great job managing our women through this phase of life. There are calls to action everywhere. Just last night, I was reading an article that I stumbled upon on the internet. It was a submission by my own college, the Royal Australian College of GPs, and it was an inquiry into issues related to menopause and perimenopause submitted to the Senate Community Affairs References Committee, a document that is calling for change. In that document, they pretty much outline how we need to do better management and better education to not only our medicos, but society as well, and to the women going through this, and all of those around her that are in a position to support her. The document highlights that good medical care in this time period takes longer consults than what we're funded to provide. these issues are complex and they take time to address. I didn't even know this document existed. I imagined that there are other medicos out there like me recognizing this gap, but I hadn't realized there are steps already being taken behind the scenes to remedy it, which I was really thrilled to see. So this document was released in February, so just a couple of months ago. So it's really timely. At the same time, I have seen lots of other doctors from other places like America and the UK being very vocal about the need for change in this area. And that was part of the motivation for me wanting to do my part here in Australia. So I want to give you a little backstory from my own personal experience that's also helped lead me in this direction to do this project. So some years ago, I started having some changes of my own. I didn't actually recognize them to be perimenopausal changes because they weren't hot flushes, which is the typical symptom that we look for as medicos. It also fits with the study done by Davis et al. In 2021 titled Healthcare Providers' Views of Menopause and Its Management, a Qualitative Study. They conclude that upskilling of providers urgently needs to be addressed. Apparently, according to the study, we're knowledgeable about menopause. However, we're only treating those women with severe symptoms, which is only about 20% of the women going through this. What this says to me is in line with my own experience that we're not recognizing perimenopause, those initial elusive symptoms that we can do something about, that women don't have to suffer through. And that seems to be the general consensus with a lot of women I see, is that they just need to grin and bear it, just get through it. Or maybe there's some kind of badge of honor of getting through it without any kind of help. But again, we need to discuss what the risks are and the things that we need to be doing to protect ourselves in the long term. So once I worked out what I was going through, and I guess part of that was accepting that I was aging and I was actually getting to this stage in my life, and that's a hurdle in itself, that acceptance around that, I started to reflect on my own management of women going through this stage, and I realized I was not doing as well as I could be doing, and I wanted to do better. And I did recognize that that was partially related to how little education we get in this area. So I've gone out on my own and found more education. I've done a lot more reading. I've done more courses to educate myself better so that I could do better in this area for my patients. I've tried lots and lots of things myself. So I'm going to give you some of those experience. I know firsthand what works. I practice what I preach. So listen up, ladies. I've got some good information for you here. So I think we need to start with some definitions because, as I said, I think a lot of people are still a bit confused about what is happening when. Okay, so perimenopause, menopause, and postmenopause are all based around what is happening with your reproductive system, in particular, your ovaries. So in our ovaries, we have all of the eggs that we're ever going to have when we're born. We actually start losing some of those eggs even before we're born. So we call it menopause when we are completely out of eggs. But menopause is really just one day in time. It's diagnosed when there's been 12 months since you've had a period, and there's no other good reason not to have a period, and you're in the appropriate age group. So the average age of menopause in Australia is 51. It normally happens between the ages of 45 and 55. If it happens between 40 and 45, then that's called early menopause. If you're under 40, then that's premature menopause. And that timeline's really important when it comes to management. So perimenopause is that time when the pesky symptoms generally start. It's that time before you have your last period and before you hit the 12-month mark of no period and hit menopause. So menopause, just one day. Perimenopause, that time leading up to it. During the perimenopause, we're getting to the bottom of the barrel, so to speak, with our eggs. So at 30 years old, we only have about 10% of our eggs left. At 40 years old, we only have about 3%. Our ovaries make a special kind of estrogen called estradiol, and when they run out of eggs, they stop making it. Estradiol is a powerful anti-inflammatory hormone, and we have receptors all over our body, which accounts for all the different systems that we get symptoms in. There's still so much we don't know about how estrogen affects us and about all of the other estrogen receptors in different areas of our bodies. I just read a study the other day about glaucoma, which is a dangerous eye condition that can lead to blindness. We know that women get it more than men, and we now know there are estrogen receptors in the eye, and we're now wondering if menopause is a risk factor for glaucoma. But like many, many, many other things in this field, we need more research. Okay, so that time leading up to the menopause is, in terms of our hormones, very chaotic. Our hormone levels become really unpredictable. You can think of it like every month your body is trying so hard to get one of those eggs prepared for ovulation, and it's digging deep to the bottom of that barrel, so to speak. Some months it's successful, some months it's not. Some months you're going to have an oversurge of estrogen, and some months you're not going to have enough. So that explains the chaos that's happening with your hormones, which then is affecting all of those organ systems in your body. The amount of estrogen we have becomes very unstable. Now, the symptoms of perimenopause generally last, it really depends on what you read, but the general consensus lasts for 4 to 8 years, but it can be less than a year and up to 10 years before you finally hit that 12-month no period and therefore can say you've gone through menopause and now you're in post-menopause. But that does not mean that the symptoms stop. Just because you've hit menopause, you've gone through it, and now you're in postmenopause, and you're in postmenopause for every day after that, most of us will generally still have symptoms, often maybe just a few more years, but they can continue on for another 10 years. It is really important that we understand why it's important that we get the management right. So once we go through menopause and that beautiful estrogen isn't there doing what it does in our bodies, other things happen, as I said, behind the scenes that put us at risk. Our cholesterol profile changes, and some of you may have seen this. You've always had good cholesterol, and then all of a sudden your cholesterol's gone up and you haven't done anything differently. Our bad cholesterol goes up and our good cholesterol goes down. We become at increased risk of heart disease. The estrogen isn't there to protect our bones, so we can end up with weak bones. It's called osteoporosis. Now, an important note here, a lot of people get osteoporosis and osteoarthritis mixed up. Osteoporosis doesn't have any symptoms unless you fall over and break a bone. Osteoarthritis is inflammation of your joints that causes joint pain. Totally different mechanism. Osteoarthritis starts with osteopenia, where they're weakening, and then when they get to a certain point where they're very fragile, it becomes osteoporosis. And this puts us at risk of fractures, just tripping over something. Trip over, break a wrist, or the more dreaded hip fracture. What we know is that 1 in 3 women over the age of 65 are going to fracture a hip. That's compared to 1 in 10 men over the age of 65. So we are at increased risk, and there's something that we can do about it. A third of these people who fracture their hip won't make it past 12 months. They won't even make it out of the hospital. Another third will lose their independence. They will need help from day to day with just general basic care. So a lot of those will end up in a nursing home. 65, that's not that old. The other third that get their hip fixed and they get on with business are still at increased risk of death from all-cause mortality, so lots of different causes over the next 10 years. And then to compound everything, our muscle mass that already has started to decline in our 30s, so we just naturally start losing muscle, that process starts picking up the pace around menopause, and we lose even more muscle more rapidly. This puts us at even increased risk of osteoporosis because our muscles protect our bones. They also help maintain our function so that we don't fall over as easily. We can catch ourselves if we trip. There's more padding around our bones. Losing this muscle mass also further decreases our metabolism, which then contributes to even more weight gain. One of the main problems with the weight gain that we have around menopause is that a good portion of it is due to what we call visceral fat. This is fat that surrounds our organs, and this is why our waists expand. So our waist to hip ratio increases. This visceral fat is known to be associated with an increased risk of heart disease, breast cancer, uterine cancer, diabetes, high blood pressure, stroke, and sleep apnea. And that's only off the top of the list. The good news is that we have lots of tools in our toolbox to manage this stage in our lives. We just have to identify it and make a management plan. So this information is for you to consider and take to your GP and have a chat with them about what's happening with you. Could this be perimenopause? Could it be something else? We need to do further investigations and make a management plan. This is a really good time to talk about the fact that there is no diagnostic test for this stage of our life. People often come in and ask if we could do a hormone blood test. We do have a hormone blood test, but we generally only use that in special circumstances because, as you just heard me say, our hormones are so labile and unpredictable, you just can't trust one number in time. So we only tend to use that blood test, which is an FSH test, if the picture's not overly clear, especially if they're going through early or premature menopause, or if the picture's clouded because they've got a contraceptive implant of some sort. So don't expect your doctor to run a test to be able to diagnose perimenopause for you. It really is a clinical diagnosis and a diagnosis of exclusion of other things that could be causing the symptoms. Now, in the next episode, we're going to take a deep dive into all of those management options. We're going to talk about hormone replacement therapy, which is now known as menopause hormone treatment. We're going to talk about the conundrum and why doctors are often afraid to prescribe it, why we're only giving it to those women with severe symptoms, and why women might be afraid to take it. We're going to talk about how we've all been duped by a study that was released over 20 years ago, and it completely changed how we manage our patients in this phase of their lives. A study that was inaccurate in the claims that it made and how we know that to be true, but we're still slow to come around in changing the way that we manage women in this phase of their life. I'm going to talk you through it. So I hope you'll join me again next time as we navigate our way through this stage of our lives together and opt to thrive. Have a great couple of weeks, everyone. The Opt to Thrive podcast is designed for information purposes only and is not engaged in the giving of medical advice. The information provided on the podcast should not be used for diagnosing or treating a health problem or disease. In no way should the information provided by Opt to Thrive be considered medical advice, and at all times the advice of a medical professional should supersede recommendations from Opt to Thrive. If you have or suspect you may have a health problem, you should consult your healthcare provider. The views expressed in this podcast are purely that of Dr. Sims and do not in any way reflect those of the institutions she contracts with medical services to.
Thank you for listening to Opt to Thrive. If you've enjoyed listening, please rate and share the podcast. You can visit our website at www.opttothrive.com and leave a comment for any subjects you would like to hear more about.